Our members are fed up. Our perception is we're getting equally terrible health care.
We're simply not making the optimal use of the services we now have.
You know, we were trying to tell you 10 years ago that this was going to happen and nobody was listening.
From the Zoomerplex in historic Liberty Village, the Zoomer with Marissa Lennox.
Welcome to the Zoomer. I'm Marissa Lennox. On today's show, we take an in-depth look at our healthcare system. Workers are burnt out and quitting in droves. Surgical wait times are long and getting longer. Millions do not have access to a family doctor, and Canada's emergency rooms are struggling to stay open. It's reignited the perennial debate here in Canada over how to fix healthcare. And the big question, would more privatization solve the crisis? We have an all-star panel lined up to discuss. But before we dive in, let's tee up the topic.
When Tommy Douglas introduced Medicare to Canadians, did he ever envision the crisis it would be in today? From Ashcroft, British Columbia, to Whitburn, Newfoundland and Labrador, healthcare workers are burned out, and emergency departments face closures due to shortages. Over the summer, more than 6 hospitals were partially closed in Quebec. At least 5 saw closures in New Brunswick. More than 20 hospitals in Ontario closed ERs, beds, and ICU units. And a third of rural Manitoba ERs closed due to staff shortages. Some point to burnout as the culprit. And COVID pushed it to the brink of collapse. Is a private-public system a solution, or is it a distraction from healthcare's deep institutional problems? With a crisis decades in the making, finding the silver bullet will be no easy task.
All right, let's bring in the panel now. I know your time is valuable, so I really appreciate you all taking the time. First of all, Dr. Sheikh, anyone who's been following the news closely can see that this is a system in crisis. There's not even the faintest question there. Some have even referred to it as a system in collapse. Paint a picture for us, because it's one thing to read about what's happening, it's another to experience it.
Well, I think our healthcare system, like every healthcare system in the world, has faced tremendous strain from the COVID-19 pandemic, as well as we had many challenges going into the pandemic that have only gotten worse. And for example, our hospitals routinely operate at 100% or more capacity. And every flu season, you would see that our emergency departments would be overwhelmed and our hospitals would be overrun. We've always had this issue for a very long time of patients who are awaiting long-term care, and that's been in the news a lot lately. And all of these things have just gotten worse since COVID. But, you know, the bones of our healthcare system are strong. The bones of Medicare are strong, and we need to build on that foundation and ensure that our healthcare system continues to provide care based on people's need rather than ability to pay.
So that's one perspective. Others have referred to this as a system in collapse, Andre, and it's interesting because this crisis is a little familiar to me. I mean, we all remember hallway medicine. It's not as if ER closures are anything new, but something does feel different this time. Do you look at this as a system in collapse?
I think our system has profound structural problems. I agree with the previous speaker that I think we have good principles, you know, that no one should be denied care because of an inability to pay. But I don't think we've created a system to deliver on that. We have a very shaky foundation, a very poor primary care, a very hospital-centric system that's really top-heavy and doesn't do enough primary care. So I think every problem we have in Canada is really structural in nature. We have great healthcare workers, we have good principles, but we just haven't put them into action with a good system to deliver on those principles.
Catherine, would you agree with that assessment?
Well, I've referred to it as the Titanic and it's sinking, and it goes back a long, long way with cuts to nursing back in the previous PC government, the Liberals not doing anything about it over the years. And you know what, during if we dial back to SARS, if we looked at that SARS commission report where the late Justice Archie Campbell said, you need to pay attention to your human health resources. And if there's ever another pandemic, we will be in trouble. No one looked at that report and took it serious, and they should have, because here we are in another pandemic and we're in trouble.
We are talking about our healthcare system today, David, and it is not an exaggeration to say that people are literally dying waiting for care. But, you know, this is just a couple of headlines from the past year alone. A Montreal woman, 91, dies waiting 7 hours for an ambulance. Patient dies in ER at Red Deer Regional Hospital as wait times spike 14 hours on the weekend. And this just happened. A woman says she blacked out from pain during a 19-hour wait in Windsor before learning she has cancer. These are far from extraordinary.
That's right. And I think the problem is that we've taken the principle of ability to pay, which CARP certainly endorses, that you should not be denied that on the grounds of inability to pay. But we've translated that into this almost religious fervor or fear of the P word, privatization. In Ontario right now, we have 5, 6, 7 tiers of healthcare with privatization everywhere. Try and get a physiotherapist, try to get a dentist. So we've already got this. And the notion that the government has to both pay, which is valid, equalize out, take care of the people that can't pay, but also be the manager and the supplier and the administrator and the deliverer of these services, when in fact the world is populated with other jurisdictions that are not identified with runaway, capitalism, but have hybrid models where the government still looks after the people that can't pay and yet is able to increase the supply. And I agree with what you said about cutbacks to nursing. We have a supply problem, we have a human resources problem, and the idea that the government as a single funnel is going to be able to fix it, run it, deliver it all by themselves, our members can't wait any longer. And we are not interested in ideology, we're interested in outcomes. And I don't see how we can get the outcomes without loosening this up a little bit.
Well, and I also think, Dr. Gorfinkel, that a lot of the pressure on our hospitals and our emergency rooms more recently stems from the fact that so many Canadians don't have a family doctor. And so the makeup of who's ending up in the emergency room looks a little bit different than, say, some of these European countries. I mean, people are ending up there for requisitions for blood work or for stitches. Is there a shortage of GPs? What's going on?
So it's a serious issue, and it's happening on several levels. Not only are there not enough family doctors to go around, but the family doctors who are there are not being utilized to their top efficiency. So in addition to dealing with more retirements, early retirements than we expected, we're dealing with the record high levels of burnout right now and mental health problems among clinicians. So these all add to the problems that COVID-19 has already set us up for. Absenteeism in record high numbers. And when doctors cannot work for 10 days, or sometimes longer because of being infected with COVID-19, it sets us even further behind that 8 ball.
All right, hold that thought because we'll pick this up on the other side. Don't go away. Welcome back. The health human resources crisis appears to be the most acute problem facing our hospitals at the moment due to burnout, low pay, extreme stress from the pandemic, not to mention options of going elsewhere. Catherine, can you put some numbers to this crisis for us? How many say that they are burnt out and how many have actually quit or left the profession?
Well, we were estimating a need of about 22,000 nurses. We're around 30,000 now. And what's really interesting is I'm actually had breakfast this morning with the president from Nova Scotia, of which she thanked me for all the Ontario nurses that have gone to Nova Scotia. So the issues are in our province that we need to fix so that we can get our nurses back from the States and from other provinces.
How about other components of the healthcare workforce, Dr. Sheikh? Surgeons, other physicians, diagnostic technicians, are they in short supply too?
Well, I think one of probably our biggest crisis is in the nursing profession. At least that's what I see in my emergency department, where we're routinely short-staffed by at least a few nurses every shift. We actually do have hospital capacity to do more surgeries, but we just don't have the people to do them. And often it's not the surgeons, it's the nurses and the orderlies and all the other healthcare professionals that we need to actually have a functioning healthcare system.
In Ontario, the government has taken steps to fix this. One of them is to fast-track foreign nurses. Do you have confidence in that process to bring in more nurses?
That's not one answer. That's many answers depending on the country, depending on the specifics of the individual's training, and also depending on their own level of experience. So it concerns me because when we invite foreign medical nursing or foreign medical graduates, you're talking about a very disparate group, a group that can have the proper credentialing and another group that absolutely may not. And I don't believe that the healthcare crisis is an invitation to extend licensure to individuals who may in fact not be qualified to do the job. Desperation does not mean hiring the wrong people. It means being smart about how we handle the funds and hiring the correct people to do the job.
Is that a risk, hiring the wrong people?
Absolutely, it's a risk. We cannot ignore that. It's a reality.
But getting them in isn't the answer. I agree with you on competent and qualified, but once they're in, nursing is different in different countries. We need nurses to mentor them, and we do not have the available staff right now to mentor. When you're an RN and you have 15 patients in a medicine unit, you cannot also mentor a new graduate or an international nurse. That is very problematic. We need to just drill down to the root problem, and it is staffing. Privatization isn't the answer. We're putting the cart before the horse.
Okay, but so to fill the void, hospitals are spending big dollars, Catherine, on agency nurses and on agency workers who cost a lot more money than staff. And we're actually seeing an exodus. Correct me if I'm wrong, because you're the expert. But as I understand, there's been a bit of an exodus, too, from the public sector. Well, it's not exactly they're leaving the public sector, but they're leaving the hospitals and going to these private agencies. Should we out and out ban that process?
Well, I wouldn't say ban it, but it needs to be capped because historically they've been used in nursing homes, just because nursing homes do not appear to want to hire people full time. But it is an abuse of our healthcare dollars. Our government is supposed to be the caretaker of those dollars, and they're not. So what we're seeing happen is nurses are leaving their place of employment, going to an agency, and returning to the same place of employment. Instead of making $38 an hour, they're making $100, even more than that. And then the agencies are billing out. That's clear abuse of healthcare dollars, and that needs to end.
Andre, there are two sides to the personnel challenge. Obviously, there's the supply side, but that's exacerbated by the demand side. And there are more and more people ending up in hospital. People are living longer, well into their 70s, 80s, 90s with several chronic conditions. Do you get the sense that the government prepared for this?
I think we haven't prepared at all. We haven't reacted to our demographics. I wrote a book 25 years ago that talked about the impending nursing shortage. There's no secrets here. We just have not addressed these fundamental problems for a long time. We have all these short-term measures. Oh, let's bring in some nurses from the Philippines. Let's hire some agency nurses, but we never have a fundamental solution to these things. And that's why I always talk about structural issues. So we don't have a health human resource plan. We talk about issues separately. Let's deal with nurses. Let's deal with personal support workers, but we have to at some point decide how many people do we need to care for our population, and then we have to figure out how to do that with training, with retention. I think one of the biggest issues is we have a lot of nurses in this country who aren't working as nurses because it's hard work and it's not flexible, et cetera. So there's a whole bunch of things we can do, but they have to begin with a plan, and we have no plan.
But I want to make one point here. With all these topics, it seems to me that the managers of the system need to be held more accountable for these mistakes. And I think that you can't fix it with the same people that got us into the jackpot in the first place.
David, I'm going to be very gentle in the pushback, but
Okay.
I am going to push back a little bit.
Don't be gentle.
In that, we cannot continually keep playing this finger-pointing game. The finger-pointing game isn't going to work.
Okay.
We've got a system which is crazy difficult to manage. It's insanely complex. People get into this position and really don't know much. It takes years to learn this much about a system which is incredibly siloed and complicated. So it's easy to just erect the gallows and hang one individual. But in the end, how much further ahead are we really?
Okay.
But in order to do what you're saying, you have to have the staff. And I think you can hang out one person, here, I guess, out to dry, because right now the government isn't utilizing people that they have to offer and help. Like let's go when the College of Nurses took away the diploma program. Did they open up enough seats in the university programs to count on the lost graduates from the diploma program? No. Did the light bulb go on for anyone to say, oh, in 10 years now, we're going to really be short nurses? We have nurse practitioners that can be utilized in family doctors' offices. Why are they not? Let's look at the dentists. 1 dentist, 10 hygienists. Why don't we have 1 GP and 10 nurse practitioners? Why aren't we looking at utilizing things like that? But no one wants to talk about it. Everyone wants to be the last say, instead of collectively, let's work together to fix this problem. And the suggestions that are coming out with innovation are wrong. Privatization, maybe down the road some, not saying I agree with it or disagree with it, but we're in trouble right now. We need to take those dollars that's going to go into the private system, invest them into the public system. Because what's going to happen to your ORs, I'm sorry, I have to finish on this because I believe in this immensely. If you open up the privatization, they're going to take the easy surgeries. They're going to take the surgeries that are going to make the money, and they're going to put them in private clinics. They're going to take the staff, they're going to take the jobs. So the people that need the cancer surgeries, the open heart, the emergency surgeries, they are going to suffer because the easy dollars now have gone into the pockets of somebody else and have not stayed into the hospital system. And there won't be the staff for those open heart surgeries.
All right, hold your thoughts because I'm coming up against a hard break. And I know you had something to say, Dr. Sheikh, but we'll get back to you on the other side. Don't go away. We'll be right back. Welcome back. I'd like to welcome Dr. Brett Belchetz, co-founder and CEO of the fee-for-service virtual healthcare app Maple. Dr. Belchetz, welcome to the program. In a previous life, you and I have had many conversations about this, but it's been a while, and I'm curious your thoughts, sort of a broad take on the current healthcare crisis.
I think this is something that has been brewing for a long time. And for many years, many of us that work in this healthcare system really expected that at some point in time, the system was going to hit a crisis point like this. Even if I go back in time 10 years ago, working in my emergency room, it was very clear that every single year our patient volumes were going up. Every single year our budgets were not, our staffing was not. We were constantly struggling on an ongoing basis to keep our emergency room open, to have nurses staff the department, to have physicians come on board and fill the shifts. This is not new. It was only really a question of when would the breaking point arrive. And I think the pandemic got us to the point that tipped us over into crisis. And for any of us that are in the system, I think that the honest response here is, we were trying to tell you 10 years ago that this was going to happen and nobody was listening.
A friend of mine uses Maple, and she is a staunch defender of universality and of Medicare, but she uses it for referrals and for requisitions because she does not have access to a family doctor. Now, this is a fee for service. It's not paid by OHIP. Is that the void you were trying to fill?
The void that we were trying to fill is the accessibility void. So universal access to a waiting list is not universal access to care. And unfortunately, the reality in Canada is that for many Canadians, what they have is access to a waiting list and not very much access to real care. So about 15% of Canadians have no family doctor. And if you look at the statistics of those Canadians that are fortunate enough to have a family doctor, many of them do not have convenient or timely access to their family doctor. So you've got 1/3 of Canadians with a family doctor that are waiting more than 7 days for an appointment, even with their own family doctor. Now, for anybody out there who's run out of their medication, who has a new symptom like a urinary tract infection, et cetera, that is developing, you know that you cannot wait 7 days to see a doctor because those things that start out as minor symptoms could actually turn into a true emergency in that period of time. So it was very clear to me working in the emergency room that most of my patients were coming into the emergency room, not because they had the true definition of an emergency, but because they were desperate. They had no family doctor or their family doctor was not available for them to see when they actually needed timely access. And so people were waiting 8 hours for 5 minutes of my time. And it was very clear that that 8 hours was costing them dearly in terms of lost wages, et cetera, from their jobs, and in terms of lost productivity, childcare, and all the other things that they would have had to deal with, and exposing them to infectious illness potentially in the emergency room, waiting room. And there had to be a better way, and that's what we were trying to provide.
Okay, I'm going to put you on the spot here before I open it up to the panel, but do you believe more privatization is the answer to solving this crisis? And what would that look like?
Yeah, I think we have this very narrow point of view around privatization here in Canada. Unfortunately, privatization has been vilified as this terrible, terrible endpoint. And people always point to the United States, where people who don't have the means to get private insurance are denied care. And I think that's one example out of the entire world, and it's not the example that we should be looking at. So when you look globally around the world, every single developed world nation, you want to look at France, Germany, Switzerland, Sweden, Japan, Australia, New Zealand, every single other developed world nation has universal healthcare like we have, and they have a hybrid system that also includes private care. And every single one of those countries has better stats than our country in terms of access, and actually even better stats around equity. So the equity of care, the fairness with which those people of greater means can access care versus those people with lesser means. In fact, Canada doesn't even do well in terms of equity. So my answer to that question is not, should we have more privatization? Should we have less privatization? My answer is, let's look at what is working better in the rest of the developed world. And let's look at what we're doing, which is we are the only country in the Western developed world that does not allow private care. And let's actually look at the results of those two systems, and let's emulate what seems to be working better than our own system.
Dr. Sheikh.
So let's look at those countries that people who are proponents of privatization keep bringing up. There are peer countries in the OECD, excluding the United States. And it's true, they do have a parallel private system. They also spend more publicly as a share of their healthcare spending than we do.
We are actually one of the leaders in terms of per capita spending on healthcare versus any of these other countries.
But as a proportion of our healthcare spending,
spending less per capita.
Out of every dollar spent in Canada on healthcare, 30 cents is private. And the average in these countries that people compare us to is 15 cents is private. And so they have larger shares of their healthcare spending as being public. They cover more things than we do here. Things like dental care, pharmacare, long-term care, home care. And so that's why they do better on equity, not because of the fact that some people can pay to get to the front of the line. We have a shortage of family physicians in this country. We have people who can't access primary care. If we take some of those doctors and we put them into a for-profit system, all we're doing is making it harder for the people who already can't find a family doctor.
To me, the issue is we have to stop talking about private-public as a dichotomy, as a black and white issue. As we heard from the last two people, every country has a mix of private and public healthcare. I think what Canada does poorly is we don't define what's covered publicly, what are our expectations that you cover privately. It's all very murky and it's unfair as a result. So I think that's what other countries do differently, is not that they have more private care. I think they just define it and they regulate it better, and they also administer their public systems better. I think in Canada, we really have the worst of both worlds. We have terribly administered public systems and kind of a Wild West of private systems. So something like Maple, I think that's a great service, but there's no reason we couldn't do that same service within a public system. But we just have to decide, where does it belong? And we have to be clearer with the public. I don't think the public has a problem with spending. As you heard, we have one of the highest rates of private spending in the world. What they don't like is the lack of clarity and the unfairness of our system.
The word private, the way it's used here, is devoid of meaning for me as a patient, because it could mean that the supplier is private and his or her fees are subsidized or even paid for by the government. The issue is, if I have to go to a private supplier, will the government help me, or am I on my own? That's the first, and there's nothing that stopped them from helping you even under a private supply system. Final point is that what about the equity of the government forbidding people by law from spending their own money, if they choose to do so, to save their own lives, to better their health care? No, you can't do that. We're happy in our sort of ideological hamstrung world to say, well, at least everybody's getting equally terrible health care. Is that the big win that we've achieved here? Is that what we're...
Public health is there to be the voice for the voiceless. The most vulnerable don't have that voice. And that's a serious problem with just suggesting open the floodgates to private care. That's not what we can do, because think about it.
Nobody's saying open the floodgates.
If somebody is to incentivize this GP, and let's just say, for example, $5,000 a head, which is out there. That's actually happening. And it's called concierge care. Be there for me 24/7. Be there at my beck and call. What'll happen is I could fill my entire roster like that. And you know what? Iris Gorfinkel would be one less GP servicing a system that is in crisis right now. So let's not ignore that. That's a real fact. So we have to look at what countries have done and what countries have done successfully and say, what can I learn from this and how can I take that
But with
to
respect,
put it into
other
Canada?
countries require people in the private system to take a certain percentage of people in the. There are models here that we're not even looking at. My complaint is we're just using the dreaded P word as this kind of a almost incantation that is stopping us from looking at reasonable management reform. Nobody's saying about open the floodgate. We're not, our members are fed up. We're not getting what we want. Our perception is we're getting equally terrible health care. That's the win here. Oh, well, at least everybody else is waiting just as long as you are. And I'm here to say to the group of professionals who I respect greatly, we're tired of waiting.
All right, hold your thoughts. We will pick this up on the other side. Don't go away. Welcome back to the program. We've been discussing efforts to stabilize Ontario's health care system, and one such effort was announced by the Ford government. That includes increasing the number of publicly funded surgeries performed at private clinics. In other words, finding more supply through the private system without eliminating a single payer. Dr. Sheikh, broad strokes first. Were you pleased to see this announcement? Is this the right direction?
So I was not pleased to see this announcement. I think it's important that we publicly fund these surgeries, which is what the government has committed to. But it is also committed to expanding private for-pay delivery, or private for-profit delivery. And it's important to make that distinction about who's paying and who's delivering the care. There is no reason why we can't provide high-quality care and high-volume care to reduce the surgical backlog without lining the pockets of shareholders. We have great examples in this province of private, not-for-profit delivered care. It does exactly that. High volume cataract surgeries, high volume procedures. And we know that we're gonna end up spending more to get the same results or even worse results. And we're gonna line the pockets of shareholders with public dollars at the same time.
Dr. Gorfinkel, would you agree?
To some degree, I absolutely do. But on the other hand, the system needs some give. There has to be some give in all of this. One thing I know for sure, the siloed care we now have is not working. So breaking down the silos, as Alberta has done, and as, in terms of having one electronic health record for the province, is a major step in the right direction. Because we're simply not making the optimal use of the services we now have. And that's a serious problem. Is this problem going to be solved by Maple Care, by what it does in terms of virtual care? I have grave concerns about the quality of care that can be delivered on a computer screen. And that's because if I lose my physical examination, the human touch, the human interaction, I've lost a tremendous amount in medicine. I'm more likely to order labs. I'm more likely to order x-rays. And of course, all of this has significant downstream effects, as I've had to learn in the pandemic.
Dr. Belchatz, I'll get you to respond to what Dr. Gorfinkel's just said, and maybe also comment on the announcement by the Ford government.
Yeah, so I think we as physicians are trained to make decisions and judgments based on data, not on gut feel. And what we just heard was gut feel. There's lots of data on virtual care. Kaiser Permanente, one of the largest healthcare providers in the world, was doing 50% of their visits virtually even before the pandemic. So they were doing millions. They are 10 million patients in that. They were doing millions of visits per year virtually long before we ever hit the pandemic. And they have tons of data to show that the accuracy of diagnosis, the outcomes from those visits were just as good as the in-person visits. So nobody's suggesting that every visit should be done virtually, but it's very clear that a certain percentage of visits do not require a hands-on physical examination for accurate diagnosis. And there's no reason to force those people into a clinic to travel across town, sit in a waiting room, et cetera, for those visits. So again, were we saying 100% of visits should be virtual? Yes, we are in a bad place to be. But at the right percentage of visits, there's no data to support the claim that was just made.
Whoa,
so that was a very
whoa. No one was suggesting that virtual care is one thing or another. I wasn't suggesting that we should throw out virtual care. What I was suggesting, in my defense, is simply to say that we need to do that with our eyes wide open. And I don't say that there's not a place for virtual care. Of course there is. But I can tell you, we need to be very thoughtful about what that place is and not open that floodgate.
Go ahead, Dr. Melchis.
Again, I think we're talking about a gut feeling, and I'll wait for the data to come out. I've seen bad medicine practiced in the emergency room. I've seen bad medicine practiced in walk-in clinics. So yes, there is bad medicine practiced in the virtual world. The bigger question is there more bad medicine that we're seeing in the virtual world versus walk-in clinics versus the emergency room? And the data that exists to date doesn't support that. I'm happy to see what it looks like for Canada. But until we have that data, I certainly wouldn't be leaping to conclusions such as what we've heard. The final question is, my response to the Ford government's announcement about increased privatization of delivery of surgeries. I think the bigger question is related to what we were discussing in the past here is, does this increase supply versus take supply out of the existing system? That's the only question we should be asking. So by having extra private providers of surgeries, will we enable or incentivize our existing nurses to give more hours to the OR? Will we get our existing surgeons to give more hours to the OR, et cetera, et cetera, et cetera? Because if this plan allows us to open up excess capacity that didn't exist before, then it's a good plan. If all we're doing is transferring supply that existed in the public system to a private system, no, we're not really accomplishing very much by doing this.
Catherine, your thoughts?
Well, let's say I'm having a hernia repair done. It's cost X amount of dollars in a public hospital, and then Schuldeis's hernias, how much does it cost there? Say it's $4,000 difference. I don't know. Why aren't we taking that $4,000 and investing it into the current system we have to provide better care and to increase the surgeries there? So to me, we're just lining the pockets of of shareholders. And although the health minister said the OHIP card will work, tap, 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 like the grocery store, at the end of the day, the money's coming from the government. Where's the government money come from? They'll increase our provincial tax dollars if they're going to pay it that way. So we're paying for it in the end. Invest in what we have now, fix what's broken before we move on.
Andre, I'll give you the final word here.
The bottom line is people don't care who provides their care. They want their hips, they want their knees, they want their cataracts, they want their hernia repairs, and they want it delivered promptly and efficiently and safely. And that's what we have to focus on. We can figure out the private-public distinctions, we can regulate better, but that's what we have to focus on. Get people the care that they need, whether it's a primary care physician, surgery, et cetera, and we're just not delivering.
All right, stick around. We'll be right back with more of the Zoomer. Before the break, we were talking about the pressures on our healthcare system, specifically in our hospitals, and one of those pressures stems from ALC patients, or alternate level of care. These are patients who don't need medical help anymore, but stay in the hospitals occupying beds because they have nowhere to go, in some cases for months to years. Dr. Shea, give us a sense of the sort of scope of this problem. What are you seeing in your hospitals?
This is a huge challenge, and it's a challenge that precedes the pandemic. When you have patients getting the wrong care in the wrong place, like these ALC patients staying in hospital, the downstream effects are enormous. So it means that there's less beds on the floor for acutely ill medicine patients. It means that those medicine patients end up staying in the emergency department. And in my Toronto hospital, where there's 20 acute beds, sometimes 18 of them will be filled with admitted patients. And it's like having a 2-bed emergency department in downtown Toronto. You would never build that system. And so the downstream consequences are huge. And this is a great example of how funding the care is not enough. We need our government to actually coordinate the care, because it makes no sense to spend money in this way. But if we provide the right care in the right place for the right patient, we'll provide better quality care, we'll provide more efficient care, and it will save us money.
40% of the patients, Catherine, in hospital are on a wait list. ALC patients in hospital are on a wait list for long-term care. And in a move to free up these beds, the Ontario government passed Bill 7, which essentially permits them to move patients out of these beds and into a home not of their choosing. Would you agree with this bill? What was sort of your reaction to it?
I'm not happy with the bill, no. As someone that has had family in long-term care. I couldn't imagine my mother being 300 kilometers away from me, because that's where she would have to go if they actually follow through with this. And as far as for nursing, we are now going to be forced into pushing families into agreeing to this, talking to them, our care coordinators. People should have the right to agree to where they're going, to their bed, consent. And Bill 7 takes away their right to consent, and that is absolutely wrong. People that are in long-term care need their families.
I think getting back to the ALC problem, I don't think we recognize just how bad it is. There's about 7,500 ALC patients Canada-wide. So that's the equivalent. We have about 20 hospitals full of people who don't need to be in hospital. This is a huge waste of money, and it just speaks to this domino effect. If you don't get ALC patients out, you don't have people in long-term care, you don't have enough home care, all of this stuff is connected, but our system operates in silos. So again, it always comes back to this lack of connection, lack of organization, lack of administration.
Well, and then the other issue I see, and it's something that Catherine's been talking about, which is our labor shortage. But what about the labor shortage in long-term care homes?
Absolutely. When this family doctor listens to the crisis that we're in, especially the ALC, I'm reminded we definitely need some level of privatization. This is a draconian measure. It's a desperate measure. It's a measure being done, it's actually being kind of thrusted on patients, not without their consent, without their family's consent. It's going to add burnout to physicians. It's going to add burnout to nurses who have to tell them this. And the fact of the matter is, it's making a lot of people feel very uncomfortable and very unhappy. And this is where some level of privatization may make sense. Of course, what makes the most sense is having kept them out of that situation in the first place and keeping them at home as long as possible. And from this GP's perspective, that is simply not happening.
It does feel like a missed opportunity. There was nothing mentioned about home care in this bill.
Home care, yeah, that's the problem there. As a user, actually, of the system, because I chose to keep my mother home with me for 8 years, the home care system is a private system, but lacks staff also. And they have no accountability. So, and especially if they don't have a family member to take care of them, they don't always even get their visits. An elderly person could be left in bed all day, no food, no water, no medication, because there was no commitment from home care to go to that patient's home. So unless you have a family member policing it, it's a very scary situation to put a loved one in.
I have to cut you off because that's it for time for this segment, but we'll be right back. Don't go away. Welcome back to theZoomer. Before we go, as always, we like to get to some of your comments and questions, and so we may just have time for one today. But the first is from Janice. She's in Cobble Beach, and here's what she writes. She writes, my family doctor recently retired. Finding a new one at this point is next to impossible. My husband is sick, sometimes in need of referrals. What advice do you have for me? Dr. Gorfinkel.
It's such a tough situation, and I'm inundated with questions from even within Toronto. Can you be my family doctor? It's a struggle. So the College of Physicians and Surgeons of Ontario and most colleges across the country do have lists of family doctors who are accepting patients. And unfortunately, the list is fairly brief. In some areas, it's non-existent. So what to do? That's when we start looking to virtual care to help solve some of these issues. If it's a matter of a prescription refill on a drug that somebody has been stable on for some time, even that requires care to make sure that the safety and efficacy have been proven and shown. So it's not a one-size-fits-all, and all I can say is do the best you can. There may be nurse practitioners who are coming. There may be incentives that could be offered by politicians to get doctors and nurses within that area, but it's a serious problem across Canada.
All right, that's it for time, but with just a few minutes left, can we get some final thoughts from each of you? Dr. Gorfinkel, I'll start with you on this one.
What we need to do is not consider it an either or. There is space in Canada for privatization, but we need to do it very thoughtfully. We need to look at other countries to understand what has been effective and what has failed. You know, there's no crime in failure. There is crime, I believe, in finger pointing. We need to have an inclusive conversation about what is working and what's not, and try to run with those things that we know are successful and optimize what we currently have.
Dr. Sheikh.
I think that we have to look at the evidence. And the evidence is pretty clear that when you have a limited number of resources like we have and you allow people to pay to get to the front of the line, you just rearrange the line. And when we pay public dollars for-profit, investor-owned delivered care, all we're doing is lining the pockets of shareholders rather than actually incentivizing the best quality care at the most efficient way. And that's where we need our government to really take ownership of our system, responsibility for it, and better coordinate the care, break down these silos, and put the health of Ontarians first.
Catherine.
I agree with that 100%. I think we need to fix our public system first, drill down to the root cause. It's staffing. That's why the emerges are closing, beds are closing. We need to look at that before we move forward with anything else. And there are things we could do, but it will take time.
Andre.
You know, I think that there's a place for private, there's a place for public. We have to figure out where are those lines. We need more clarity. The final thing I would say, you know, we're all this talk of crisis. Let's not forget, we have a pretty good system. We deliver good care despite ourselves, and we shouldn't get too down. We should focus on fixing it. It's fixable, and let's not lose sight of that.
I'd like to change the context a little because I'm not the expert. I'm the least expert person here, but I would like to think I understand what this age group, and particularly our members, want. And I'm here to tell you about the consumerization of this entire thing, that we're not caught up in public versus private. We don't think private is good. We don't think private is bad. We don't think private means opening the floodgates, or it could be private but not for profit. We want outcomes. We want better health care, and by definition, CARP being for older Canadians. We're not interested in waiting 10 more years or 15 more years for this famous system to fix itself. You gotta fix it, or else we'll find other set of politicians.
All right, David, we'll have to leave it there. That is it for time. A big thank you to my panelists for joining today and for your expertise, and for you at home watching. As always, it's great to have you. We'll see you next time. For now, it's time to zoom out.